Now it is time for the presidential address, which I've rehearsed for decades here just to get ready for this talk. Let's see, last night actually, no. So I think the message that I want to leave with you this morning is pretty much captured all on this slide. It's all about the evidence. The scientific evidence that you contribute to the field is immeasurably valuable to the prevention of healthcare-associated infections. In contrast to, you're probably familiar with a cyclist called Lance Armstrong. He said it's not about the bike. This one I'm taking a little bit of a parable on this, reversing a little bit, but it is all about the evidence in terms of what you do at the bedside and implementing new findings in the literature to improve patient care and safety. And the quote from Goethe here is particularly, I think, apropos. Knowing is not enough, we must apply. Willing is not enough, we must do. So I thought I'd go back to the literature just a few years, and here's some early evidence that the Japanese actually believed in hygiene much earlier than the U.S. and even the European model. So hygiene in Japan from the mid-1600s, to the mid-1800s contrasted sharply with that in the U.S. And Europe, which would have played an important role in reducing disease. A visitor's account from the late 1600s, it was an invariable custom of both nobles and commoners to wash their hands every time after using the privy, separate eating utensils, and removal of footwear when entering homes and buildings. And this is a graphic actually of infant mortality against consumption of hand hygiene products. And you can see the higher on the x-axis that you used consumption of hand hygiene products, the infant mortality dropped significantly. So kudos to our friends from Japan because they were way ahead of us in hygiene and early adopters. This is actually a wonderful supplement, somewhat biased, but probably the best journal ever published, the American Journal of Infection Control, by my good friend Dr. Alison Aiello and her co-authors, including Elaine Larson. So we were thrilled to be able to do the supplement and very good information. So I would encourage you to take a look at that. So what about APIC's core competencies? How do we support you as the member? And I think this slide captures it all. We are clearly member-focused and patient-centered, and we do that through education, practice guidelines and research, and public affairs, public policy. And I will attest to you that I had no inkling the amount of public policy that would come across my desk this year, but my email's been bombarded constantly, and kudos to our APIC headquarters staff and you as the members. Through your grassroots, through chapter activities and information, we're finding out what's going on in the states, and that's kind of really boiling up to, on a national and international level, what types of things do we have to deal with to make our patients safe. The foundation of that, certainly membership, human resources, our finances have to be sound and solid. Development, informatics, we're going to talk a little bit about, and how we govern and market our what we know in terms of getting in front of patients and making sure they're aware of the infection preventionist. So here is an old quote, but an important quote from a noted authority in our field. The current state of surveillance and public reporting, I thought, was too apropos this morning. Healthcare data, the infection preventionist and epidemiologist Sand comments on the quantity and quality of data. Sand, tiny discrete particles with substance, but basically without fixed structure, frequently accumulating in forms of great beauty or built into castles, are subject to winds of change and waves of fad and politics. In this elemental form, sand and data present great danger, able to blind us or even bury us. Anybody have a clue as to who said this? Walter Hierholzer, someone's in the first row. Must have gotten the pre-copy of the slides, but that's exactly right. Dr. Hierholzer, so you get an extra cookie today at lunch, Vicki, so good job. So yes, Dr. Hierholzer, I thought this was entirely apropos, and I'm sure it resonates well with all of you. The amount of data that we're being asked to produce on an almost daily basis escalates logarithmically, and I think we need to really support the infection preventionists, but also make sure our consumers and providers understand that this comes with a huge burden. We need to lessen that burden, I think, is one of our missions going forward. Thank you. So I think a good illustration of this, you can see what the state of required laws, in other words, mandatory reporting in 2003. Only 2 states, our friends from Pennsylvania and Illinois, had something enacted then. Look by 2010, the number of laws that have been introduced for basically public reporting, transparency, and disclosure of healthcare-associated infection information. And this year, that entire map has been filled in completely in terms of the U.S. from the Centers for Medicare and Medicaid Services, which, as of next January, will begin to report all episodes of central line-associated bloodstream infection in intensive care unit patient populations. So this emergence has been almost whirlwind on a tour, and I'm a little bit concerned that the amount of data is going to begin to bury us and actually blind us in terms of what we're really after. So one of the key principles to do this logically is data for action, or principle, one of these is meaningful use, as Steve mentioned earlier. So data for local action, very important. I think this happens at a grassroots level. So you've heard lots of success stories maybe in other facilities. I think how it applies to you is how do you engage teams, get a hold of your direct care providers and help them prevent infection. You're a supportive role, but certainly a key stakeholder in that. We do a lot of data comparison and trends. Elevate that up to a regional or state action level, and one thing that I think is positive about public reporting is that we've seen an explosion in the networking and opportunities with our partners in public health. So local public health, state public health, and CDC, I think, has been an encouraging and absolutely wonderful trend to see as we look at data management and information for patients. And so obviously on a national level, we have new metrics from the Health and Human Services that are looking at HAIs on a countrywide level and asking that we do better, make sure our patients are aware of how we're doing, and use this data and play well in our sandbox. So this is the most important thing from our photo snaps here is use that sand appropriately, sift through that data, and make it meaningful and practical for patients. So how do we spend our time? This is a pie chart from a superb study by our good friend Rachel Strickoff and her colleagues in the great state of New York. But look at please do applaud for our research. This is application of research. So what's the biggest piece of the pie there? Surveillance, almost 45% of our time, some aspect related to surveillance. So it's an incredible kind of portion of our time. And here's the typical infection preventionist, what they do. So your average scope of responsibilities, typical infection preventionists in the state of New York. So hold on to your hats. You're responsible for 151 acute care facility beds. You're responsible for 1.3 intensive care unit beds with an average size of 16 beds in each of those. You're also responsible for 21 long-term care facility beds. 0.6 dialysis centers, not sure what happened to the other 0.4, but we are going to look for those soon. 0.5 ambulatory surgery centers, 4.8 ambulatory outpatient clinics and other locations for care, and 1.1 private physician practices or private care practices. Are you tired at this point? So I think this really demonstrates the amount of scope that is, I think, unique to the field of infection prevention. We're pulled in so many directions that we have to do this smartly and figure out maybe some new strategies to more efficiently do this. Also looking at this on a nationwide scale, my colleagues Sarah Krein and Dr. Sanjay Sain have done some long-term studies looking at 2005 and 2009, and we're looking at staffing effectiveness. So you can see the number of beds surveyed was about the same between 2005 and 2009. One thing, a trend that is notable there, as you can see, certainly there's been a real logarithmic growth in the number of facilities that have a hospitalist. So there's a key partner that's potentially available for you to tap into for a variety of infection prevention activities. I'm somewhat chagrined that the line just below that, the number of full-time equivalents that you and I provide to our providers, has not changed significantly. It's been 1.3 in 2005, 1.5 in 2009 overall. The lead infection preventionist certified has also stayed about the same. However, the good news is I think this collaborative model has really gained a foothold, especially in the U.S. and North America, but also outside of the U.S. And you can see almost 68% of hospitals have some types of collaborative aimed at prevention of healthcare-associated infections. So very encouraging trend, and I think that's a great model. So why do we do this surveillance stuff all the time, day in, day out? I think there's some encouraging trends here recently reported in MMWR back in March. You can see the number of central line-associated bloodstream infections in intensive care unit were well over 40,000 back in 2001. Look at the tremendous power of the collaborative for National Healthcare Safety Network. Drop that down to maybe 18,000 at the most. Significant reductions in certain pathogens which are problematic. As you can see, 73% drop in the frequency of staph infections as a cause of central line infections, 55% Enterobacteriaceae reduction, Candida, and even other gram-negative organisms. So we've had some significant progress. We've saved 27,000 lives in this process and saved probably $1.8 billion in healthcare costs. So give yourselves a round of applause because you are part of this network. And nothing would be complete without recognizing and acknowledging National Healthcare Safety Network's been really the bedrock of how we collect data, the methods, the detection of these infections, and the reporting. And you can see all of the components currently within the National Healthcare Safety Network. My personal comment is HAI surveillance is not easy, but NHSN is the gold standard, mom and apple pie, all wrapped up into one. So I think that's our take-home quote for today. So how are we doing at the bedside? Are we getting evidence that you are aware of in the literature actually directly to the patient's bedside? Here's some interesting findings again from Dr. Krine's investigation, 2005, 2009, and you can see on a national, focus on the green and the red. Michigan, I'm not sure what we're doing there actually in terms of prevention, so ignore that data. But bladder ultrasounds, clearly this is a technique to actually avoid use of insertion of urinary catheters. Still, maybe about 39% of facilities are using this technique, some alternatives to urinary catheterization. One thing that's striking there, you can see despite some evidence, which I'm going to show you in the next slide, only about 20% of U.S. hospitals are reminding clinicians that a urinary catheter is present in their patient and asking them to get that catheter out. This is inversely proportional to the level of education. So the more education you got, the less awareness that you have of that your patient has a urinary catheter. So if you're an attending physician, you kind of peek in the door, say hi, and make sure everybody's okay inside there. But you don't see that fully urinary catheter hanging off the other side of the bed. So only about 40% of attending physicians are aware their patients have a urinary catheter. Now that goes up a little bit. The resident is a little bit more aware. That's up to about 50 to 60%. Guess who knows the catheter's in place and what's happening? The medical student who's been assigned to insert that device and care and maintain that. About 80% of them are aware that their patients have a urinary catheter. So awareness, I think, is a key thing. Antimicrobial urinary catheters has increased, as you can see, nationwide there. One thing also a little bit chagrin, there's some good evidence that cooperative males can use a condom catheter very safely and avoid the insertion of an indwelling catheter. I think the operative term there is cooperative males, I think, is the problem with this particular. There's something genetic in that particular formula that I think we have to improve. So, but I mentioned about awareness of the catheter. This is a meta-analysis of a number of studies that looked at both reminder systems that the urinary catheter is in place in the stop order. We just saw on the previous slide only 20% of us are using some type of awareness technique, but overall that dropped the frequency of catheter-associated UTIs in half. So a simple technique of awareness can have a lot of power in terms of avoiding these complications in our patients. So what's the right way to do this? Let's focus on the process. So on your, let's see, your left, obviously we want the bag off the floor, probably not in the patient's lap, and probably the worst place is the IV pole. That's an interesting place to have your drainage bag. It takes a lot of force to get it up there, but the correct way is on the far panel over here that shows to keep that, obviously, drainage bag below the level of the bladder. So these processes of care are very important, I think, especially with prevention of device-associated infections. So since it's all about the evidence, where is the evidence before us? How about the science right here at APIC 2011? And we're honored to have some both international and national representatives. And is Dr. Maekawa in the room by any chance? There he is. And hopefully by modern technology, we'll be able to show you Dr. Maekawa and me. So my first question is, Dr. Maekawa, what brings you to Baltimore? I think that was my...
Thank you, Mr. President. Briefly speaking, my conclusion, I have two conclusions. Firstly, MDRPA was likely to acquired in elderly and severe burn patients. Secondly, MDRPA acquisition is associated with prolonged hospital stay, but did not reduce survival rate in burn patient. Thank you.
Great, very good. Thank you very much. All right. So Dr. Makau will be presenting this at, I think, an oral session coming up this week. One of my asks for all of you is to make sure you go to the posters. I'm not sure where they are, but they're somewhere here. Upstairs? Okay, good. So upstairs, folks, just mosey on up there and spend some time with both the oral presentations, but also, importantly, the hard copy posters are going to be available all week. So very important to have that at that particular avenue. The other thing that Sapporo is famous for, actually, I can attest to this, they have one of the best beers in the universe. So while you're there visiting Dr. Makau, you can also imbibe a little bit if that's your pleasure. Also wanted to recognize some science right here, right now, a Blue Ribbon Abstract Award winner, and this is Ms. Peggy Ann Hazami, and she has done a nice abstract with her colleagues determining accuracy of central line associated bloodstream infection data submission for public reporting in hospital-acquired infections in New York State from 2007 to 2009. So Peggy, my first question is validation of CLABSI important?
Well, yes, it is very important. As you mentioned, the HAI surveillance is not easy. So part of the validation of the CLABSI data in New York State, what we have done is make sure that the hospitals understand the reporting criteria, and if they don't, we help with the education of that. We also use that to make sure that the reporting is accurate for more consistent data comparisons. It also helps look at the process of and success of your prevention activities. So that's more consistent data for that. And of course, in New York State, since it is mandatory reporting, we want to make sure that we provide to the public information that is fair, reliable, and accurate.
Very good. Thank you, Peggy. That's great. Awesome. And was only able to pick 3, but the new Investigator Award, we're particularly pleased that Dr. Groda, hopefully she's in the room, yes she is, right in front of the row, did a wonderful investigation of patient factors associated with adverse events of hospitalized veterans in infection control isolation. We all know and love isolation or contact precautions. My question, Dr. Groda, is being placed, so if you place me in isolation, is that bad for my health or well-being?
Russell, I'm glad you asked that question, and my research actually is very interested in continuing to explore that, and it's still out. We still don't know. It's evolving evidence. I think what's important for infection preventionists and for our field is to determine what is the different elements in the word isolation and contact precautions, and my study found that there was no association of adverse events with isolation or contact precautions, wow. That it truly is related to patient characteristics and probably also to some of the higher team systems and processes that are in place. But I particularly challenge us to look at the word isolation, because as we look at that, as our length of stay has decreased, I think our findings are showing that isolation is not the cause of adverse events or not associated with those, including healthcare-associated infections.
Great. Well, thank you, Dr. Groda. Perfect recap. Very good. So I think that's just a taste of some of the, there's, I can't remember how many, 300 posters or abstracts that will be presented. So lots of rich data, and that's where the evidence is. That's where we have expertise, is applying that evidence to the patient bedside, the implementation science. So I'm going to go back to my good friend, the Lone Ranger here. So this was an editorial that Dr. Elaine Larson wrote back in year 2000 around identification of what are our priorities in terms of the research project. I thought these were so apropos that they apply right now as much as they did 10 years ago. So at the systems level, change incentives for clinicians and researchers to work together across institutions and organizations. So that is right on the mark, and if you've heard a term called the Accountable Care Organization, we're all in this together. There'll basically be payment for one patient, and we need to provide care for them for their acute care needs, home care, long-term care, medical home concept, all of that range in the spectrum of care delivery, and ambulatory care, obviously a lot of interface. So if you thought attribution in NHSN was hard, before. You ain't seen nothing yet, so just wait before we start. Hopefully we won't be pointing fingers, but working together really to make a safe journey for that patient. At the individual level, as Steve mentioned, we occasionally feel isolated ourselves, so the advice here in this editorial was to stop hunkering down and riding the range alone. Actively expand your role in practice beyond infection control, beyond a single healthcare setting, beyond your discipline. Assess and improve the effectiveness and efficacy of your own practice. Move towards evidence-based practice. And that was 10 years ago plus, so we'd really like to acknowledge Dr. Larson for a very insightful quote that applies as we sit here right now as much as it did back then. So what are we doing to eliminate healthcare-associated infections? Again, that's our ultimate goal, to prevent all of these. We want to collect data and disseminate the results. I think you've seen some demonstration of the power of surveillance is sharing the findings, not the collection. That's the part of the journey, but it's really giving that data to clinicians to use to improve care. Full adherence to best practices. I think we've got some challenges there. We want to recognize and celebrate what you and your colleagues are doing in your facilities. Obviously, you have to respond to emerging threats, and who would have thought that outbreak within the northern part of Germany would be spread almost on a global level. So we had cases in the U.S. and throughout many other countries around there. Most recently in the U.S., we have resurgence of an interesting little viral infection that you may have heard of called measles, and that's related directly to international travel. So we really need to look on a global level, I think, to infection prevention. And improve science for prevention through research. Obviously, that's where I think our strength is to look at what works, what can we bring to the table in terms of prevention aspects. Michelle Farber and her group are working on a new competency model for the infection preventionists. I think what you see here, we have lots of expertise in the technical competency. What we're looking at, I think, is vitally important is a platform of leadership. And so we want to encourage some skills, because I think the infection preventionists really currently is at the table. There's a lot of focus on what we do. I think we need to deliver on that, and we're going to need some new skills to be able to do that, to communicate and work with performance improvement colleagues or patient safety, quality improvement, and really work together in a core competency model that's going to improve the infection preventionists and our efficacy going forward. One way to do that, obviously, is clearly obtain your certification in infection prevention and control. Certification is clearly a commitment to personal professional development, I think, over and above any other benefit. So it really is your own journey. I would encourage you strongly to pursue certification. And so with that, let's take a look at the data, since we're all data-driven, and what percentage of APIC members have obtained their certification in infection control, infection prevention and control. What do you think? 99%. I like that. I like that a lot. Let's see what the number shows. Oh my gosh, 19%. So of all members within APIC, about 19% have obtained their CIC. So we're going to mind the gap. So our good colleagues from the UK are very careful in letting us know that there's a gap present in between the train as you mount that. We want to really improve. Here's where we'd like to be. So just about 1% higher than our estimate. So with that, I would encourage you all to pursue certification, and we've got lots of good content this week that's going to help you prepare for that. Next tip, obviously we talked about evidence-based care. We want to look at where do we find the evidence. Obviously, this is the ultimate place. You don't have to go anywhere else. There's no other journals that, no, Steve, sorry. Steve Gordon's about ready to hit me with a penknife in the back here. But they publish an excellent journal as well, Infection Control and Hospital Epidemiology. But your first assignment is to sign up for the electronic table of contents. So there's a new issue alert that tells you both papers that are in press and also very soon to be published. So do go to the website, sign up for that. Your second assignment, where is the evidence? Right at your fingertips. So if you've got your smartphone, you can do this right now. But go to the PubMed, which is, you can see a tremendous, over 20 million citations currently within the PubMed database. If I can't think of a day that I'm not at my office that a question doesn't come up, this is where I go first to see if anybody else, such as yourselves, have figured out how to tackle a particular problem. Readily available 24/7, 365 days a year, and you can do a search and find out what your colleagues are doing, publishing, and it's a rich source of information. If that fails and you're out in the middle of Aberdeen, South Dakota, you can find a medical librarian, I'll guarantee you, who will be instrumental in getting you to the evidence. So there's lots of resources for you to grab onto. I did want to recognize some work of a group called the APIC Science, Knowledge, and Implementation Network, or ASKIN. So just asking us if you want to. No disparaging remarks for my southern colleagues there. So research needs of the infection preventionists. We did a repeat of the study looking at research priorities done in 2000. These are the highlights that Mark's going to go over in more detail at the annual business meeting coming up on Tuesday afternoon. MDRO, not surprisingly, some of those pathogens that we're all familiar with, a lot of challenges. Isolation, just what Dr. Grode was saying here, we've got some evidence readily available to answer some of those questions. The environment is kind of wax and wane. In the early 70s, we said the environment wasn't important. Now it's resurged with a vengeance. So the environment of care, preventing surgical site infections, infection prevention in alternative settings, new technology, devices, and disinfectants. Most importantly, we saw we need to improve staffing and infrastructure for infection preventionists and the economics and business case development. So how do we get to making surveillance less burdensome? This is a module in development, so electronic surveillance through the National Healthcare Safety Network. I also would encourage you to explore surveillance technologies. APIC has published a position paper on use of automation that will help make your job easier, and hopefully more accessible to your direct care colleagues so you can go up and help support prevention activities at the patient bedside. This is a trend I see emerging pretty quickly, is that much more dependence on surveillance technology, automation as much as possible. And my vision for maybe next year, if Dr. Pollack and Teresa Orhan and our good friends at NHSN can do this, but wouldn't it be nice if the laboratory could directly report electronically laboratory ID, MRSA, C. diff, VRE, Acinetobacter, Stenotrophomonas. So I think we're on the precipice of that. So we'll keep working with our good friends down there. Another important piece, I think a trend of the future, is before your eyes glaze over and I talk about MICs and pharmacodynamics of vancomycin versus troughs and peaks and all that good stuff. I can see I've lost the audience. Everybody's leaving the exits. But antimicrobial stewardship is what you do. I think you collect a lot of data. This is put up here for twofold. I never knew there was a journal called Implementation Science, but here's a place where you can publish your findings on what works in terms of getting this. This is a nice project developed by some folks out of Texas called Kicking Caudy, the No Knee-Jerk Antibiotics Campaign. So here's an example that there's a rich opportunity for us to look at things that we're collecting already and share. We do a lot of MDRO surveillance and C. diff infection surveillance. We need to share that with our colleagues to show what our antimicrobial stewardship program is like. So would encourage you to get involved with that. We are developing a position paper that describes the role of the infection preventionists, and Julia Moody with HCA is heading that up on our behalf. She'll be talking about some of the highlights of the draft of that right here this week. So please go by Julie's session. Just to wrap up, I wanted to highlight a wonderful talk at SHEA 2011 by Dr. Sanjay Saint, The Art and Science of Implementation, the Role of Leadership and Followership in Preventing Infection. And here's some skills that Sanjay felt are important for us as we go forward for infection preventionists and healthcare epidemiologists in the future. So what are these? Future training should include implementation science, we've been talking a lot about, leadership and management, communication skills, teamwork, negotiation, human factors engineering, organizational behavior, and group psychology. All of these are the softer skills that we may not be as familiar with, but I think they're absolutely essential. The last one there, organizational behavior and group psychology, absolutely is going to be critical if we're going to get hand hygiene up to that 99 to 100% level all the time, all 3 shifts, around the clock. So that's going to be some challenges for us going forward. I think we have lots to learn from social scientists that we need to begin connecting with them as well. Certainly will help us deal better with the reality of preventing infection in real-world settings. Also wanted to highlight we need a partnership for patients, recently launched by Health and Human Services. We were honored to be at the kickoff for this particular project, and I think that's really where the rubber meets the road. We need to connect with our patients. I'm envisioning not too far away, probably it's already happened, is you come in on your Monday morning and get a phone call, and it's the patient up in 302B and says, I think I may have an infection. Can you come on up and let's talk about it? So I think that is coming soon, where the infection preventionist is going to be real-time consult And what Steve mentioned, he's going to highlight some other aspects of that, but we need to have a presence right at that bedside as well and not be afraid to talk to our patients. So the goals for this partnership for patients include reducing all hospital-acquired conditions, so these are all complications, pressure ulcers, medication errors, HAIs included, by 40% by year 2013, and also complications so that we don't have patients coming back into the hospital after too brief of a stay. We let them go too soon, and they have complications after their discharge and they're coming back. Ultimately, we're going to obviously do the right thing for the patients and also save money. So quality is free. As we've heard from Cliff Orm, our member of our board of directors, has coined that term, and I think I agree wholeheartedly in that project. Here's the model that's coming. This is the state of the future. We're all going to be in this surveillance network together, so we need to work together and collaborate. And I'd like to thank you for your time and attention. Your third assignment is to go to the oral abstracts and presentations. We couldn't get this video clip posted, but your another assignment is to go to YouTube and look for the video called Dignity and Grace from Young Frankenstein, and it'll explain this entire session completely. It's how to accept failure with dignity and grace, and Dr. Frankenstein shows us how to do this with skill and culture and sensitivity. And with that, fire up your browsers. I look forward to seeing you on the internet, and thank you for your time and attention.